Good evening. I'm Kelly Gear-Ripken, National Chair of A Women's Journey. On behalf of Johns Hopkins Medicine's A Women's Journey, thank you for joining this evening for our monthly webcast series, Conversations That Matter. A Women's Journey strives to improve your well-being through health education. With summer approaching, we are going to focus on melanoma this evening. I am pleased to introduce our speaker, Dr. William Sharfman, Associate Professor of Oncology. Please use the Q&A on your screen to pose your questions throughout the evening. Following our conversation, Dr. Sharfman will respond to many of your questions. Tonight's webcast will conclude at 8 p.m. I want to take this opportunity to acknowledge and thank Johns Hopkins University's program, Hopkins at Home, for their production assistance. You can visit their website for additional lectures and courses throughout the year. And now I am pleased to begin tonight's conversation with Dr. Sharfman.
Thank you. Good evening. It's a real honor for me to be here to speak as part of the Women's Journey series. I hope to convey to you tonight the remarkable advances that have been made in melanoma treatment over the past 10 plus years. We've gone from helping 5% to 50% of patients with advanced melanoma. I always said when we stop giving chemotherapy to treat melanoma, I know we are making real progress. And now we rarely use chemotherapy in our treatment of patients. We use much more modern treatment. Today, I want to share with you the key discoveries, the pivotal trials, some patient stories, and future directions in melanoma research. Just so we're all on the same page, a definition of immunotherapy, which is where most of our advances have been made. Immunotherapy is a type of therapy that uses substances to stimulate or suppress the immune system, help the body fight cancer, infection, and disease. And this is what really makes sense to patients, to doctors, to treat cancer, not with toxic chemicals, but to turn on the immune system to fight the cancer. And that's what we're able to do now in many cases of melanoma. Immunotherapy is not new. This is a picture of Dr. Cooley. Over 100 years ago, he came up with Cooley's toxin, a method of injecting dead bacteria into patients that would stimulate the immune system with the hope of fighting cancer. And some of you may remember this cover from Time magazine. This is 1980. At that time I was in medical school, and we thought the interferon was going to be the way we would treat and cure cancer in the future. Unfortunately, that did not quite pan out. But by 2013, cancer immunotherapy was considered the breakthrough treatment of the year in 2013. And at that time, the excitement was really building and new treatments were really working for patients with melanoma and other types of cancer. Before I get into the meat of the talk, I want to present a case which I think shows the power and the potential of immunotherapy. And every time I go over this case, I still tear up a little bit. This is the story of MC. She is a 37-year-old woman with widely metastatic melanoma. She had no past medical history. She was married. She had twin 7-year-old boys with autism, and she taught physics at the Naval Academy. She came to us with metastatic melanoma. At that time, we had a trial giving two drugs together, which I'm going to talk about in more detail, one called Yervo and one called Opdivo. After 12 weeks, she got into a complete remission. She had absolutely no side effects from the treatment, which was unusual, and she was and continued to be in a complete remission. And 3 years out from starting the treatment, she called me and said, "Dr. Sharfman, I'd like to have a little baby." And I said, "Well, I don't know if that's a good idea. You just had metastatic melanoma. I just don't know if it's safe. I don't know if it's a good idea." But so, you know what? I'm 41 now. It's going to happen. It has to happen now. And so here she is, a little baby, a beautiful little baby. Her mom had metastatic melanoma 4 years before, but mom is fine. The baby is healthy as can be. And that is really a beautiful story. And that is what we want when we treat cancer patients. If we can't prevent the cancer, we give them a treatment that has no side effects. They go into a complete remission, and then they go back to their normal lives and do everything they were doing before. That's what we really want for all our patients. So let's just talk about some basics of melanoma before I get into the treatment of more advanced disease. And when we think about how melanoma happens, just take a look at this picture of the skin. And in the top layer of the skin at the bottom, you see these melanocytes, and these are what become melanoma if they are irritated. And we think that in most cases of melanoma happen from the UV exposure from the sun. It irritates the melanocytes, it causes mutations, and over time, melanoma will develop. And everybody has probably seen these pictures, and really we should all be aware of them, whether we're doctors, patients, just anybody should be aware of the ABCDs of melanoma. This is to help you know when to go to the dermatologist, to the doctor for a biopsy. The A stands for asymmetry, the B stands for irregular borders, C stands for variation in color, D is for diameter, something more than 6 millimeters. Then a few years ago, the E category was added. That is evolution. That is a skin lesion that is changing, something new, something changing, something getting bigger. In an adult, we really shouldn't have pigmented lesions getting bigger or changing or showing up new. And so these are signs that you really get things checked out. Now, it turns out that despite people being aware of melanoma, the incidence of melanoma continues to rise in the United States. And in fact, as of 2 years, this is the most recent data. As of 2 years ago, we were over 100,000 cases a year, more in men than in women. Men on this side, women on this side. Melanoma is becoming fifth most common cause of cancer in women. Fortunately, it is not a top 10 cause of death from cancer in the United States. In fact, in most cases, the vast majority of patients with melanoma have very early melanomas. The treatment is surgical removal. Sometimes it's very simple surgery, and most patients are cured. Occasionally, people are not cured and the disease progresses. But what is very reassuring, very exciting, is that the death rate from melanoma has actually gone down in the last 10 years, from close to 9,000 deaths per year in the United States down to 7,000 per year. And we think that's probably from early detection, and also we believe probably from the availability of new therapies for treating advanced melanoma. I am not an expert on melanoma prevention, but I just want to mention a couple things. We can prevent melanomas by using good sunscreens. The higher SPF, the better. Almost all sunscreens have UVA and UVB protection, so it's not hard to find them. There was some controversy whether anything was better than the 30 SPF, but it does appear the higher the better. Annual skin checks, I think it's a good idea by a dermatologist. There's actually controversy whether that's helpful or not. There is some downside to doing annual skin checks because some people have biopsies that were not necessary. They have scarring from the biopsies, but if you ask me, an adult should have an annual skin check. Particularly the fairer you are and the more mole you are, the more helpful it would be to have an annual skin check. And of course, avoid tanning booths. This still seems to be a problem with our younger patients. Now let's move into treatment of advanced melanoma, which is where I spend most of my time. And back in 2010, for treating advanced melanoma, we had very limited tools. We had chemotherapy and one immunotherapy called IL-2. And this article came out in 2008, which was very depressing. We got a lot of attention in the melanoma world. Over several trials of treating advanced melanoma from 1977 to 2005, there was actually no progress whatsoever. The median overall survival was only 6.2 months in metastatic melanoma, and that was really very, very upsetting, and back in 2008. But somehow, by 2021, we now have multiple treatments for melanoma that really are quite effective and can give many patients very long-lasting remissions. On this slide, there's 15 different treatments listed. The ones highlighted are the immunotherapies. I'm going to focus on those first. The other ones are called targeted therapy, and I'll talk a little bit about them at the end if I have enough time. The discoveries that brought us to modern immunotherapy for melanoma and for other skin cancers came from two gentlemen, James Allison and Dr. Hanjo. And they won the Nobel Prize in 2018 in medicine for their discoveries. And what they discovered, first of all, they understood that in the immune system of the human, that there was a balancing act, that there were cells in the immune system, particularly the T cell trying to eradicate cancer, but there were other cells and other molecules on the other side that were trying to damper down the immune response and prevent the body from eradicating cancer. Now, these different cells, these different molecules were there to damper down the immune system for a good reason, because if they weren't there, we'd all have autoimmune diseases like lupus or colitis. So these breaks, these checkpoints in the immune system were there for a good reason. But Dr. Allison and Dr. Hanjo discovered these two really important breaks, which are now called checkpoints. One was CTLA-4, and the other was called PD-1. And discovery of these two molecules was key for advancing immune therapy of melanoma. I like this poster from the Nobel Prize ceremony. It shows breaks, a foot brake and a hand brake, the CTLA-4 being the hand brake, the PD-1 being the foot brake. These brakes that are on the immune system, that these gentlemen realize we can unlock them, we can unlock the immune response to melanoma and other cancers. So the first molecule that was discovered by Dr. Allison was CTLA-4. And this molecule, let me show you how this works. This is how we think the immune system is supposed to respond to cancer. This is our T cell, the main cell in the immune system that is going to eradicate our cancer. This is the antigen presenting cell. So the antigen presenting cell presents a piece of a protein of a foreign cell, a cancer cell, to the T cell and activates it. And what should happen is that T cell should then go after the cancer that has that same protein on it. But what Dr. Allison realized was that when that happens, this molecule called CTLA-4 shows up on the surface of the T cell and puts the brakes on and prevents the T cell from eradicating the cancer. Another cartoon to look at. Again, here is the antigen presenting cell presenting a piece of the protein from the cancer cell, a foreign protein, to the T cell, and it should activate it. At the same time, the CTLA-4 molecule comes up on the T cell and turns the brakes on. And so what this drug is, this ipilimumab, or this Yervoy, it's an antibody that attaches to that CTLA-4 brake, that checkpoint, and turns it off, turns the brake off, and allows the T cell to go on and eradicate the melanoma. And in fact, when the anti-CTLA-4, or the ipilimumab, or as the trade name is Yervoy, was first tested in metastatic melanoma, it was the first time in a major randomized trial that we showed we can improve survival in metastatic melanoma. So just what this is showing you, it doesn't look very dramatic when you look at it from a distance, but in this top graph, overall survival of melanoma patients getting the ipilimumab or the Yervoy, and really only getting 4 doses. What you see is that if you got the ipilimumab or the Yervoy compared to not getting it, the chance of being alive at 12, 24, and 36 months, you doubled your chance of being alive if you got this drug. And again, that's the first time that we ever showed a drug can improve survival in melanoma. And more dramatically, sorry, little technical issue here. More dramatically, when you looked at patients and followed them for several years, these are patients that all got 4 doses of the Yervoy or ipilimumab, and only 20% benefited. That 20%, if they were doing fine at 3 years, were doing fine at 10 years. So that was really quite an astounding finding, and showed you could give an immune therapy that could put patients in a really long remission. And that really began the excitement in melanoma. Unfortunately, this drug does not work well in any other type of cancer. Now, let me tell you about one of the patients on that initial Yervoy trial. He was a 49-year-old male who was diagnosed with metastatic melanoma in 2004. He went through every imaginable treatment, every torture, IL-2, high-dose IL-2, chemotherapy, more chemotherapy, radiation, and then he relapsed again. And at that time, he got into one of the first trials of ipilimumab. He received 2 doses and then got severe colitis. It lasted 6 months. Now, that was pretty horrible to have colitis for 6 months. But finally, it was controlled, and melanoma went into a complete remission. And I've been following him ever since then. And I see him every year, do a CAT scan, and he's doing fine. At the 14-year point, he came in to see me, and he had an abnormal CAT scan. And I said, oh no, now his melanoma's come back, and I had to figure out what am I going to treat him with. But in fact, it wasn't metastatic melanoma. Just some scarring from the prior radiation. He continues to be doing fine. And now he's more than 16 years out from his 2 doses of the year ago. So quite a dramatic story. In this trial, the first trial of the Yervoy, the ipilimumab, we also learned there's a laundry list of possible side effects one could get. And these are not chemotherapy side effects. These are side effects that are due to the immune system being turned on and going a bit overboard. And you can get almost kind of any imaginable immune side effect. The common ones are rash, colitis, thyroiditis, hepatitis, and appendicitis. Most of the time, you can treat these things easily with a little bit of prednisone, but some are more difficult. It does appear that some patients with the worst side effects, worst immune side effects, are the most dramatic tumor responses, indicating the immune system has really been turned on to fight the cancer. The next key discovery was PD-1 by Dr. Andra. And PD-1 stands for programmed cell death. This is also a break, a checkpoint on the T cell. It's supposed to eradicate our melanoma or cancer. Here, a diagram showing what should happen, that an antigen-presenting cell presents a piece of a protein from a cancer cell, presents to the T cell, the T cell should be activated. But at the same time, PD-1 shows up on the surface of the T cell, and that the checkpoint. And when that checkpoint, the PD-1, interacts with the PD-L1 receptor on the tumor cell, the immune response is turned off and doesn't eradicate the cancer. So the anti-PD-1 is an antibody that attaches to the PD-1 molecule in the T cell, turns off that checkpoint, turns off the brake, and allows the immune system to respond to the cancer. Here's another way to look at it. The T cell is activated, but PD-1 shows up on the surface of the tumor, and on the tumor cell, it may have the receptor PD-L1. When they interact, the T cell response is turned off. But when we throw in an antibody, an anti-PD-1 antibody, we disrupt that interaction, and the T cell, we turn off the brake, and the T cell is allowed to respond to the cancer. And this is how it would look on a microscope slide. You have lymphocytes here that are ready to attack the melanoma. You have the melanoma cells that are stained with the PD-L1 molecule. And there, if you throw in the anti-PD-1 molecule, you allow this interaction to happen. You allow the lymphocytes to eradicate the tumor. And this is our first trial of the anti-PD-1, and it's very exciting. Patients with very advanced melanoma, over 27% of them responded. The responses were very long-lasting. And this is some follow-up, a little bit of a busy slide, but I want to show you is on the black line, the melanoma patients who got a course of anti-PD-1 or nivolumab, and here they are out at 72 months, 96 months, and almost 40% of them are fine without any further treatment. So very exciting discovery, and which brings me to the case of SH, who I saw him recently, and he says he's going to be celebrating his 60th birthday. And he says to me, "Do you know where I was when I was 50 years old?" I said, "I don't remember." He goes, "When I was 50, I had just failed my standard treatment for melanoma, and options were limited. And we got on the anti-PD-1 trial, and I went into remission. And more than 10 years later, he's fine." And he celebrated his 60th birthday. Very few side effects, leading a normal life, and enjoying his kids, his grandkids, helping his wife through a serious illness, and just doing absolutely great. and just after 2 years of treatment with PD-1 and no anti-PD-1 and no further treatment. So it makes sense then if anti-CTLA-4, if the ipilimumab or Yervoy works, and the anti-PD-1, the nivolumab works as checkpoint inhibitors and turn off the brakes. We turn off two different brakes. If you give them together, maybe it'll work better. And in fact, that has become the standard for metastatic melanoma. That if you give the combination of anti-PD-1 and anti-CTLA-4, that is nivolumab and ipilimumab, also called Yervoy and Opdivo, that at 5 years, more than half the patients are still alive if you had metastatic melanoma. We have to do better, of course, but quite a remarkable improvement from just 10 years earlier. Now, when you give the two drugs, let me just skip over that. When you give the two drugs together, you get side effects, more of these immune side effects. In fact, when you give the ipilimumab and nivolumab together, nearly 60% of patients have a very serious side effect that you're going to have to deal with. Again, most of them you can deal with some steroid. Some of them require further drugs to get the immune side effect under control. So it's a problem. When you give the two drugs together, you get lots of side effects. And one of the big areas of research is trying to figure out ways to give these therapies with less side effects that people feel more safe. These are the kind of side effects again, that are common. I mentioned thyroid, hypo or hyperthyroidism, pneumonitis, colitis, hepatitis, nephritis, uveitis. These are the common things. Again, we just give anti-PD-1 by itself. The incidence is low. When we give the two drugs together, very high incidence of serious side effects. Again, we can deal with most of them. And again, it appears that if you have a serious side effect, it often means you've had a really good response to the immunotherapy. And not only common side effects, but there's some very uncommon ones, but it can be very serious that patients have to be aware of: myasthenia gravis, myocarditis, uveitis, all things that we're aware of. We know what to look for. And again, most of the time these things can be dealt with, although sometimes it takes some work to get them back under control. I want to just go back one slide that I skipped over, and that is what a remarkable discovery a couple of years ago was if you take patients with melanoma and brain metastasis, a very difficult group of patients to treat, and you give them that same combination of immunotherapy, the ipilimumab and the nivolumab, it's remarkable that more than 50% of those patients with melanoma with brain involvement go into a long remission. In fact, it's almost the same as if you didn't have brain metastasis. And that was a little bit of a surprising finding. We didn't know how many T cells we had in the brain, whether immunotherapy could work. It's very effective for patients with melanoma who have brain involvement. And for some patients, for many patients, you can skip brain radiation, which used to be the standard of care once you have brain involvement. So that's a big breakthrough in melanoma treatment. And I should say that it's not just with the anti-PD-1, with the nivolumab treatment, it's not just melanoma now. Now it's so many different cancers respond to immunotherapy, particularly lung cancer, kidney cancer, but the list gets longer and longer every day. Esophageal cancer, lymphomas. So this anti-PD-1 treatment really broke open the dam and has been shown to be very effective in many, many tumor types, not just melanoma. So one question is how do we know what patients will respond to immune therapy? And this is a very important question. We certainly don't know all the answers, but one of the themes is patients who have cancers with a high tumor mutational burden have a lot of mutation in the tumor DNA. And this is a cartoon that tries to explain that we think cancer cells, advance by having more and more mutations in their DNA. And with each mutation, they put antigens on the surface of the tumor cell, foreign antigens on the surface of the tumor cell that the T cell, the immune system, will respond to. So the more mutations the tumor has, the more antigen shows up on the surface of the tumor cell, and the more there is for the T cell to respond to. And that seems to be a theme that's true. When figuring out which tumors can respond to immune therapy, the more mutations, the more antigen, the better the immune response. And this is a graph that may look a little bit complicated, but what it shows you is tumors and their level and the mutational burden. On this end is melanoma, lung cancer, bladder cancer, and the common theme at this end is that all these tumors have high mutational burdens. And lung cancer and bladder cancer are mainly related to the smoking, melanoma from the UVA exposure that causes multiple mutations in the DNA. Now, going off on a bit of a tangent, what was fascinating in my work is that there are tumors that have very high mutational burdens that are less common, and those are other skin cancers. And one of them is cutaneous squamous cell carcinoma, which is not common. Well, sorry, it is very common, but rarely causes a problem. It's almost always cured with a little surgery. But we're seeing more patients with advanced cutaneous squamous cell cancer. They have a very high mutational burden, so you predict that they'll be able to respond to immune therapy. And in fact, they respond dramatically well. This is a patient who had multiple surgeries. The skin squamous cell kept coming back. He's in terrible pain. After 6 weeks of being on immune therapy with anti-PD-1, his tumor went away and his pain went away within a few weeks. And he remains in remission now over 6 years. We also learned that basal cell carcinoma, another common skin cancer, which again rarely spreads and causes problems, but occasionally it does. It has a very high tumor mutational burden. It responds beautifully to immunotherapy. And Merkel cell cancer, which we're seeing more of, another skin cancer, also with a high mutational burden. This is the first paper that we were part of at Hopkins, giving pembrolizumab or Keytruda to patients with Merkel cell carcinoma and seeing over half of them respond dramatically. This is advanced Merkel cell carcinoma. And this is a great story. This is Margaret, and she has my permission to show her face on this presentation. Margaret came to us when she was 91 years old. She came with her very wonderful family, and she had metastatic Merkel cell cancer. And she came basically for me to tell her there's nothing left to do, and she should go home and get her affairs in order. But at that moment, we had a trial of the pembrolizumab with the anti-PD-1, and we talked about it, and she said, okay, let's try it. And she got her anti-PD-1, Keytruda, pembrolizumab. She went into a complete remission, and now 5 years later, or 4 years later, she's 95 and feeling great and loving life. And she's gone to too many to count weddings, too many graduations, law school graduations, college graduations of the grandchildren. And the point I want to make is one of the beauties of immunotherapy is there's not really an age limit. With chemotherapy, with bone marrow transplant, with other things we do, there's limits, but there's really not a limit with age in giving immunotherapy. And this amazing Margaret is an example of how beautifully older patients can do with immune therapy and do really well. I'm going to just talk briefly about targeted therapy because it's important in melanoma. I'll go through the slides very quickly. And this is another way to treat melanoma. It's been very effective. Again, we'll go through this quickly, but back in 2002, a major discovery was made that many melanomas had this mutation in the BRAF gene, which created an abnormal BRAF protein. And that led to a search for a drug that would turn off that abnormal BRAF protein. And this is the MAP kinase pathway, or pathway in melanoma cells that is turned on in melanoma because its BRAF gene is abnormal. And quickly, a drug was found called vemurafenib that if you gave to patients with widely metastatic melanoma, you took this anti-BRAF pill, and within 2 weeks, the melanoma almost melted away. Quite amazing when we saw this in person. Just in 14 days, dramatic responses to melanoma with the BRAF targeted therapy. And when we saw the patients in person who were so sick at this moment, and 2 weeks later, are loving life and going to a baseball game, it was just a dramatic thing to see. And in the first trial, almost everybody with the BRAF mutation who got the drug responded. But we learned quickly that the responses were very short. So we tried targeting two proteins in the pathway, the BRAF protein and the MEK protein. And that led to a trial targeting these two proteins, dabrafenib and trametinib, 2 oral therapies in patients with BRAF mutant melanoma. And this was very successful. And it turns out that some patients with BRAF mutant melanoma can take these pills and do well for a really long time. And my bottom chart here, these are patients with the kind of the lower volume of melanoma, and just taking the BRAF and MEK pill together, and 55% of them are doing fine 5 years out. And that's pretty impressive. That's as good as immunotherapy for some of these patients who are really in the better risk category. The molecular story is complicated. It's less than 50% actually do have the BRAF mutation. There's other mutations called NRAS, NF1, and NRAS, and these are also commonly seen, but we do not know how to target them. So this is a big area of research, figuring out how to target these abnormal mutations in melanoma. But I just wanted you to understand that targeted therapy was a very important piece of the treatment armamentarium for patients who have BRAF mutated melanoma. Now back to immunotherapy, excuse me. The future directions in melanoma. It turns out that besides the checkpoints of PD-1 and CTLA-4, there's many more checkpoints on the T cell and checkpoint and molecules on the tumor cell that one could potentially target. In fact, there's millions of combinations one could think of targeting 1 target, 2 targets, 3 targets. And that's been a big area of investigation. I'm very pleased to tell you that really a discovery at Hopkins by Dr. Chuck Drake many years ago, that the LAG-3 checkpoint was an important checkpoint in treating cancer and treating melanoma, led to a large clinical trial that really, this is really late-breaking news. This is presented 2 days ago at our meeting, our ASCO meeting, giving an antibody to LAG-3 and an antibody to anti-PD-1. And this again showing you what's going on. You have your T cell, which again has been turned off by these checkpoints being the PD-1 and LAG-3. And in this trial, patients got antibodies to PD-1, antibodies to LAG-3 at the same time. So turning off 2 checkpoints on the T cell. And Dr. Drake, many years ago, thought this is really a great way to treat cancer with great potential. And in fact, it looks like it's going to really pay off. And this is the trial that was presented 2 days ago, taking patients with metastatic melanoma on the bottom line, those just getting the nivolumab or anti-PD-1 by itself, on the top line getting anti-PD-1 and anti-LAG-3 at the same time. And you see at the 1 year point, many more patients have not progressed from melanoma than single agent therapy. A very exciting result, and we have to follow this further. But this looks really hot, really exciting. And what's really beautiful about this is this anti-LAG-3 drug does not seem to have many meaningful side effects beyond just giving anti-PD-1 alone. It's not like the combination of the Yervoy and Opdivo. So this is really exciting. You're going to hear a lot more about this anti-LAG-3 or lorlatinib, and not just in melanoma. You're going to be hearing a lot about it in all tumor types in the coming months and years. Very exciting. And really a homegrown treatment really coming out of the Hopkins laboratory. And going forward, though, there's just, again, millions of not millions, but many targets one could target with an antibody. It's complicated. We have to think clearly what makes sense to target, what combinations make sense, how to sequence them. And not only that, some of the breakthroughs that are happening in other cancer types are giving immunotherapy with chemotherapy, which I never thought would be a good way to go. But that's panning out in some tumor types. And then giving immunotherapy with targeted therapy, that seems to be panning out in other tumor types. So many combinations of therapy one can imagine we can try. We just have to kind of think it through and really do what makes sense, because there's way too many things out there that we could potentially try. And I'm not going to get into this in too much detail, but when you talk about immune therapy in other tumor types, there's the CAR T cells, which you may have heard about. Very exciting treatment in lymphoma and leukemia, where you transfect the T cell to recognize a tumor cell. That's an exciting area. It hasn't panned out in solid tumors like melanoma yet. Then you have something called a BiTE cell, a bispecific cell, where one end attaches to the T cell, one end attaches to the tumor cell, and it brings the T cell, the immune system, and the tumor cell together to eradicate cancer, showing activity in leukemia and lymphoma, and maybe even in a very rare disease called eye melanoma, ocular melanoma. And finishing up here, one area that's very exciting, being looked at Hopkins and many other places, is the microbiome. That the makeup of the bugs, the bacteria in one's GI tract may impact how one will respond to immunotherapy. And this is a really hot topic. And it does appear that certain bacteria make one more likely to respond to immunotherapy than other types of bacteria in the GI tract, which means that if you take an antibiotic before your immunotherapy, you may throw off the immune response, or you may make it better. Or if you take a probiotic, you may throw off the immune response, or may make it better. So we don't know exactly which bacteria you want to have. It's a very exciting area and could lead to a very simple treatment with a probiotic that just gives us the bacteria we need to have in our GI tract. I'm going to finish up by saying that right now at Hopkins in our melanoma program, we are excited about 3 new trials that are looking at patients who don't respond to anti-PD-1 or don't respond to ipilimumab, looking at one interesting drug called anti-IL-8, looking at another set of drugs that treat this NRAS mutant melanoma, which is about 20% of patients. And then we have another trial looking at another immune molecule called anti-TIGIT, which, similar to the LAG-3, is an important checkpoint, important break on the T cell. And we think if that can be targeted, we may be able to end up with a brisk immune response to cancer. And that brings me to the end of my talk. So thank you very much.
Thank you, Dr. Sharf. Thank you very much, Dr. Sharfman. Lots of information, interesting and important. So we're going to get to our questions. But before we get our viewers' questions, if you just want to clarify again, are basal cell and squamous cell cancers early signs of melanoma?
No. Basal cell and squamous cell skin cancers are different cancers. Now, patients who get one type of skin cancer are more at risk for getting other types of skin cancer. But the basal, so if you have a skin cancer, you definitely should be seeing the dermatologist for regular skin checks. But basal cell does not become melanoma. Squamous cell does not become melanoma. And I want to emphasize, basal cell and squamous cell are very common and almost always really easy to treat, and generally are eradicated with a simple surgery. And the same is true of melanoma, that for the vast majority, it's, when they're caught early, which most of them are, it's a surgery and it's eradicated for good.
Great. Thank you for clarifying that. So let's get to our viewers' questions then. You ready for that?
I'm ready.
Okay, here we go. This is from Lydia. And she asked, people who had first-degree relatives die of melanoma, have asked if they are at a higher risk of getting melanoma. And if so, how frequently should they be checked by their dermatologist?
Great, that's a good question. So we still have a lot to learn about the genetics of melanoma. And if you do genetic testing on melanoma families, sometimes you identify a gene, many times you don't. But just having one member of your family with melanoma raises your risk of getting melanoma. That's a little more complicated than that. Mm-hmm. If that person got melanoma when they're 80 years old, it's a little bit less to worry about for the rest of the family. But just having one family member with melanoma does increase the risk of you getting a melanoma. So the key then is to find a dermatologist that's going to do a very thorough head-to-toe skin examination, which can't really be done in in a minute. It takes some time. And how often do you do that? I really leave it to the dermatologist to decide. It really depends on how many moles one has. Some will have you come back every 6 months, some every 4 months. If there's really few moles, and maybe once a year. But I leave it up to the dermatologist who is doing the screening to decide how often the patient needs to be seen.
And are there specific symptoms that they should be looking for?
Well, I mean, as far as the skin, keeping those A, B, C, D, E's in mind, funny lesions, changes,
Right.
that's important. I don't want people to be looking for symptoms, and worrying about it. I mean, as far as, like internal symptoms, like pain or back pain or headache, I mean, it's unlikely that's going to be a serious problem. But I certainly, I guess symptoms that kind of persist to be checked out. But if you're a family member, I mean, if your family member had melanoma, and you don't have melanoma, I don't want you shouldn't be worried about all these symptoms going to be melanoma. About getting your skin checked over.
Okay, great. Thank you, Dr. Sharfman. Next question is from Nancy. What is Vectra WB 360 scan, the 3D whole body imaging for melanoma? And can you please tell me about the usefulness of this tool to detect related melanomas and genetic melanomas? And also, does Johns Hopkins offer it? And I'm happy to repeat any of that.
So this is a little bit out of my area.
Okay.
We have several dermatologists here that focus on following patients with pigmented lesions. And they each do things a bit differently. Some of them use a dermatoscope to look at lesions. Some of them lean heavily on taking whole body photography. I don't really get involved in that. My understanding is they're getting some new monitoring system in place. I don't know which one it's going to be, but we have some very talented dermatologists that are happy to follow the pigmented lesion patients and do the proper follow-ups.
So would you say then that really your dermatologist is probably the best resource for you as a patient, to decide whether you should get the 3D whole scan or
right.
What testing?
I mean, again, my area, the patients have already been diagnosed with melanoma, so it's not what I focus on. I think the key, though, is to make sure you identify a dermatologist that's interested in pigmented lesion patients, who's going to spend the time to look at them. And they're around, but there's other dermatologists. This is not being negative. There's some, but that's not their focus.
Right.
And so you have to make sure that, when you're going for the exam, it's a thorough scalp to the bottom of your foot examination. And if one is having difficulty finding, that dermatologist will happy to help out.
Great. Thank you. Our next question, Dr. Sharfman, is from Gail, and she wants to know, what is the criteria for immunotherapy in squamous and basal cell carcinoma?
So we're really only using the immunotherapy in the rare cases of patients with advanced basal cell carcinoma or advanced squamous cell carcinoma. That means, and that's a very small percentage of these patients. Some patients whether neglected the lesion or just unusually metastasized. So the only FDA approval now for immune therapy for basal cell and squamous cell is for inoperable or advanced tumors. We do have a trial for patients with squamous cell carcinoma that has been removed, but is thought to be high risk. And I don't have the criteria in front of me. If anyone's interested, you can email me. But it generally means a squamous cell that's quite deep, that has neurovascular invasion, and there's other criteria. And if you meet those criteria, There's a trial where the patients are randomized to getting immune therapy for a year. But
Great.
that's a clinical trial. That is not an FDA-approved use of immunotherapy.
Mhm.
No.
Okay, great. Thank you, Dr. Sharfman. Next question is from Ellen. What bacteria and the microbiome can make you more responsive to immunotherapy?
Um, I don't think we're that far along. If you want to email me, I can send some of the papers out, but I don't think we're there to tell you exactly which bacteria we know are important. We're getting there,
Mhm.
but please don't go get a probiotic and start taking it, because that's actually looks like it might be detrimental in some situations. So, but I'm happy to send you the latest papers from Hopkins and MD Anderson showing what they're showing so far. If you want to send the email on the screen.
What does a probiotic can become detrimental? What is there the
I,
specific?
no, there was a study that they looked at patients who, it wasn't a randomized prospective study. It just gave you some hint that there could be a problem. Patients who took probiotics and were on immunotherapy, it didn't improve their response rate. It looked like it made it worse. And that's not carved in stone,
Right.
but just a warning that we don't know enough yet about what the right bacteria are. I do think for patients who are about to start immunotherapy, which hopefully is nobody in the audience, you don't want to go on antibiotics unless you have to, because it does appear that starting antibiotics post immune therapy may alter the bacteria in a negative way.
I see. Again, probably the best thing is don't start anything until you've actually spoken to your doctor
I would
and let,
that's
them guide you.
Yeah.
Yep. Not the internet.
All right.
Yes. Okay. Our next question, Dr. Sharfman, is from Shanila. She would like to know, how do you participate in one of these clinical trials?
So, the clinical trials, again, that I'm involved in, generally for people with advanced melanoma or advanced other skin tumors. We do have, the adjuvant trial for the high-risk squamous cell. We also have an adjuvant meaning preventative treatment after surgery for Merkel cell. So, we just would need to see the patient, or again, if you want to email me, you can email, but, we'd have to see the patient in person, go over the issues, and see if they fit the criteria.
Okay. Thank you. Our next question, Dr. Sharfman, is from Victoria. She'd like to know, is melanoma genetic?
Well, the vast majority of melanomas are in patients who have no family history or no known family history. It does appear that, like I mentioned before, if you have one family member with melanoma, it does increase the risk of the other family members having melanoma. We don't really know the genetics in that situation. And again, there are melanoma families that clearly have some genetic abnormalities. It's the minority of melanoma patients. But when we see a patient that has two family members with melanoma, especially young, we do genetic counseling, and they'd be tested for whatever the latest known melanoma abnormalities would be.
Right.
Generally speaking, though, knowing you have the gene for melanoma doesn't change things a lot. They're going to still tell you to go to the dermatologist regularly, and they tell you to use a good sunscreen. So you have to be careful, who you do the genetic testing on. Is it really going to help them make decisions? Is it going to be some information that might get into someone else's hands that shouldn't get it? And unfortunately, genetics is just not fully developed in melanoma like it is in breast cancer. But we're making progress in that area.
Right. Right. Great. Thank you. Dr. Sharfman, this is a question from Lucia. What is the average age of melanoma, and is there one?
Um, it's skewed in my clinic because I think I see a lot of younger people, but
Hmm.
I think the average age is 50s and 60s.
Hmm.
Yeah. But it's really, I mean, one of the fascinating things about which I love about my work is I can have a 20-year-old patient in the office, and the next patient is 92 with melanoma. So it's a
Right.
very we I think there's talk about melanoma in children, but that's a very very rare thing. And in melanoma, in families
Hmm.
who worry about melanoma, we don't suggest the kids going to the dermatologist until they're beyond puberty,
Right.
of course, unless they have some funny skin lesions.
So, which kind of leads me to the next question then, Dr. Sharkman from Gina. So, she wants to know, is it the sun that causes the mutations?
Right. So in the vast majority of melanomas, it is fair skinned people like me and sun exposure, UV light, that causes the mutations in the melanocyte that over time leads to melanoma. That's the vast majority. And
Hmm.
so if one, is good about using sunscreen, um, and going to the dermatologist and all that, generally, you can decrease the incidence of melanoma, and then by going to the dermatologist, you can catch it early if it's going to happen. So yes, so the sunlight is the main culprit, but it's not the only culprit.
Right.
And there are melanomas that happen in really odd places where the sun never shines, and the genetics of that melanoma are different. We don't have BRAF mutations; we have different mutations, and it can't possibly be the sun.
Hmm.
And there's something called eye melanoma, which also has a totally different set of mutations. And we don't think that's related to the sun. But the vast majority of patients, we think it is a sun exposure issue. And the better you are about minimizing the sun exposure, and the better and even more important, the better your kids are, and younger people are about minimizing sun exposure, using sunscreens, the less we have to worry, because we think a lot of this damage happens early on in life. Now, I'm not advising people not to get out of their houses, not to go outside, not to go to the beach. You should have fun. You should relax. You should do the things you want to do, but you need to have a sunscreen on. And again, the fairer you are and the more you are, the more important it is. You should be under an umbrella if you're at the beach. And be careful, but you don't have to stop going outside. You don't have to wear a lampshade over your head. You just need to
Hmm.
be smart.
Great. Thank you, Dr. Sharkman. So, our next question for you would be: are women of color as susceptible to skin cancers as white women? And should women of color use sunscreen?
So the darker skin you are, the less likely you're going to get melanoma. So the incidence of women of color is much lower than in fair skinned Caucasian people. It's not zero.
Hmm.
Um, it does happen in my practice. I do have several patients of color that have melanoma, but it's a very small proportion. Um, some of the women of color, the darker skinned patients, have a melanoma on the bottom of the foot, which has nothing to do with sun exposure. So wearing a sunscreen is not going to help that. But general wearing a sunscreen, it's not a bad idea because it will decrease sun damage and hopefully help with aging skin as time goes on. But I don't. But there is less concern about getting melanoma and other skin cancers in the women of color.
Sure. Thank you very much. So, Dr. Schaffman, the next question from Susan: are women more susceptible to skin cancer than men?
So I didn't break it down, but it's the incidence of melanoma is higher in men than in women. So in that over 100,000 patients getting melanoma in the United States, I think the breakdown was 60% men and 40% women.
Mm-hmm.
And why, I can't explain why. I mean, I do, it is, I mean, what I see in my clinic is a lot of men like myself who have lost their hair and are old and get melanoma on their scalp, which women don't have that particular problem. But it's not totally clear why there's a gender difference.
I see. Yep. Thank you, Dr. Sharfman. The next question from Carol for Dr. Sharfman is, do autoimmune diseases increase the likelihood of melanoma?
I'm glad you asked that question because I forgot one really important point I want to say, and then I'll get to the question. When I was talking about the immune therapies, one of the big problems, I mentioned that one of the side effects is developing an autoimmune problem like colitis.
Yes.
And
Mm-hmm.
it's a big problem in patients that have underlying autoimmune disease. It becomes very tricky to give them the immune therapy because there's a potential to cause a flare of whatever immune disease they have.
Mm-hmm.
And that's a real problem because, in the United States, there's a lot of patients with autoimmune diseases. 6% of the population has rheumatoid arthritis. There's a lot of colitis. So it's still unclear which patients we can safely give immune therapy to who have underlying autoimmune diseases. All these studies that I mentioned to you, if you have an autoimmune disease, you are not allowed in the trial. So we really don't know which patients we can safely treat. Now, as far as the patients with autoimmune diseases, there does appear to be a higher incidence of skin cancer. It's a little unclear if it's the actual disease or if it's the treatment of the autoimmune disease. That the patients who are put on powerful immune suppressants like prednisone, like Cellcept, like Remicade, these things may predispose one to get all kinds of skin cancer. And a lot of the advanced squamous cell cancers I see in patients who either have underlying autoimmune disease or have organ transplant and have been on immunosuppressive therapy. So there is definitely a connection between the autoimmune patients and getting the skin cancer.
I see. So would you say then that, I know you talked about prednisone in particular, one of the medicines. Do some medicines increase your susceptibility of skin damage?
Yeah, it looks like many of the immune suppressive drugs we give do increase the risk of getting skin cancer.
Mm-hmm. So I guess if you're on any type of medication, you should probably ask your physician about that. That would be one of the questions.
Right.
Meant just to say, okay, you're prescribing these particular medicines, or here's my list of medications I'm on.
Right.
Yeah. And even though it might not even make sense to some people, right? Like if they're on some type of heart medication, for instance,
right.
They still always ask. Would you say that?
Yeah, but I certainly should ask. But I know a lot of, hear of patients who are on these immunosuppressive treatments. They're often recommended with a doctor to go see the rheumatologist on a regular basis, especially if they're on them for a long period.
Okay. Thank you. Dr. Sharfman, so how are melanomas staged or graded from mild to severe?
But we don't grade them mild to severe. They're staged 1, 2, 3, or 4. So
Okay.
Stage 1 and 2 are just increasing depth of the melanoma that the pathologist measures on the microscope. So melanoma that's less than 1 millimeter in depth is called a stage 1 melanoma. And then it goes up to 4. Everything above 4 is considered a deep melanoma. That's would be stage 2. If you have lymph node involvement, that becomes stage 3. And if you have spread beyond the lymph nodes to vital organ, that becomes stage 4.
I see.
But there's no grading system for the melanoma.
I see. Thank you for clarifying that. So Dr. Sharfman, for our closing question, would you say climate change is increasing our risk of melanoma?
I don't know the definite answer. I think that the loss of the ozone layer, more sun exposure, more direct sun exposure probably does have effect on the incidence of Like skin cancer, again, with skin cancer, again, incidence rise in the United States. So there is certainly concern that the climate may have something to do with it. But on the other hand, Australia, where the incidence was really rising quickly just by very aggressive use of sunscreens and education, we actually lowered the incidence of skin cancer. So that's kind of an interesting phenomenon.
Great. Thank you very much. Well, it looks like we're getting to the top of the hour at 8 o'clock. So I'd like to take this opportunity now to thank you, Dr. Sharfman, and each of you for joining us this evening. And Dr. Sharfman has graciously agreed to respond to any unanswered questions that were asked this evening. And you will also find relevant articles available on our website. In a couple of weeks, you'll receive an email outlining the outstanding questions and answers. And tomorrow, you'll receive an email asking you to complete a brief survey about tonight's webcast. In the coming days, a video of tonight's live streams will be available on the A Women's Journey website, hopkinsmedicine.org/a women's journey, under Conversations That Matter. And if you've enjoyed tonight's discussion, please check out our website, hopkinsmedicine.org/a women's journey, to watch for announcements about future conversations, podcasts, and special programs brought to you by A Women's Journey. In the meantime, we hope you will find our monthly email informative and engaging. Conversations That Matter is brought to you in part through a non-restrictive educational grant from Bristol Myers Squibb. Good night, wear your sunscreen, and stay well.